Dobre utro. Hi, everybody. I am very happy to be with you, with my Russian friends. Time are changing, said Bob Dylan, famous singer. And this is the exact situation we live. We are passing through difficult months, but we know that we are also learning about our future. This webinar is a perfect example of this future, and I want to thank Sergei Kashin and his collaborators for this organization. So I begin my presentation. We have perhaps some information to give you, because Italy has begun is a bad experience in February, but we know that the first virus was present in Italy also on January. The numbers are changing rapidly. We know that in Italy we are at the apex of the curve, and we are waiting to see a slow decrease in cases of infections, cases of deaths, cases of access in intensive care units. The situation in Italy is very particular. The clusters were some regions of the north of Italy, Lombardy, Emilia-Romagna, Piemonte, and Veneto, where I live. I work in Verona. It is a famous city for the Roma Arena, etc. And we are also a cluster, together with Milan, Bergamo in Lombardy, etc. We live close at our homes. We stay at homes. There is nothing on the street, and so on. Unfortunately, this region are the most productive, and so the financial problems for Italy are very great. As you can see from this drawing, fortunately, the region of the center and the south of Italy is less affected by the infection and disease. And this is very important because the hospitals, the beds, the intensive care units are less in those parts of Italy. And so this is very dangerous for them. On the left, you, however, see that the reduction of infections. This is the situation in Europe that also is rapidly changing. In this drawing of 3 days ago, you see that Italy was the second nation affected. But we know today we know that Spain has the second place. It's not good, but we know that USA is rapidly evolving with many deaths. Russia, fortunately, has a limited number, but they are gradually increasing. Which were the mistakes of political and healthy institutions? We understand that the risk of propagation was at first, at the outset, largely underestimated. And so the institutions were unprepared to face the problem. There were many mistakes in the organization in the previous years. there were a progressive reduction of beds and medical staff over the past 10 years. And so now we are unable to hospitalize all severely affected patients to the intensive care units. Now I have to rapidly create new intensive care units, new beds, but we have problem to acquire respirators and protective equipment. Another great political mistake was not to understand which were the site of propagation of infections, the main contagion points. For example, in Italy, we know that one of the cluster was the Champions League match between Atalanta Bergamo and Valencia. The same in Paris after the game of PSG. In my city, the problems was due to, at the beginning, to two Chinese positive for COVID-19. They stay in our city for some days. And also for the great number of people living in Italy due to tourist attraction. From the mistakes of health institutions, we know that, for example, in Verona, they not secured the hospitals. Patients were not adequately separated and protected, and also medical and nursing staff, so not adequately equipped with PPE. Their relatives also had unlimited access to positive COVID patients, so the subsequent spread of the infections happened to the rest of the population. This is the price we have paid for 10,000 positive cases between sanitary operators, 64 deaths from doctors, 25 from nurses, with 2 suicides. This is an unacceptable number. Which are our possibility? Nasopharyngeal swabs campaign is began with was at the initial dedicated to the medical nursing and the administrative staff of the hospital to close the cluster and avoid the diffusion of the infection to the entire population. This is the secret why South Korea, that was the second most affected nation in the world, has so limited deaths, because they began with this campaign of swabs, and also because they had young populations. In Italy, we have a very old population with many comorbidities. Subsequently, this campaign, in particular in my region, the Veneto region, will expand to a large part of population. We are, you may understand that this is the way to capture all infected patients, and knowing which are closing them at home and avoid the infections. But a serological antibody research test campaign has also just started. This is very useful. We know that today the Health Ministry said that this campaign is only possible for epidemiological searching, for research, and so we have to wait. But we know that with this serological antibody research, we know that which are the we will have the identification of the population that has already passed the COVID infection. This is very important also for financial problems, because knowing which are the men affected and which with antibodies, we know that they will be able to resume their usual production activities. So it can help to solve the difficult phase of financial reconstructions. Also, it is useful to use the plasma of these individuals that injected in the COVID-positive patients admitted to the intensive care units has a just great benefit. We are waiting to see this campaign that will obtain results in the next few months. Now we pass to discuss about endoscopic units. I work in an endoscopic one, and we know that endoscopic service now have to limit the execution of the examination to only urgent cases and for neoplastic patients. Ideally, the patients have to select before, one day before, or on the day, knowing some informations. You see that some information regard the fever of more than 37 degree, an history of travel in dangerous places, occupational exposure, contact history with COVID-positive patients, and clustering, the site in which there is many people in one place. It is in such a way that it's possible to have a correct stratification. The stratification of patients was produced as a paper, but the Canadian Association of Gastroenterology. You see the low risk, intermediate risk, and high risk patients with the indication to know them. If the procedure, after this certification, if the procedure can be safely delayed without patient harm, it may be postponed. This is a flow chart, an excellent flow chart from the Canadian Association, in which after the selection of the patients, you may decide to do urgent examination or to delay this kind of exam. But especially, which are the PPE, the protective devices that you have to use in different cases, low risk cases and high risk cases. And we see later which are the protective equipment. At the beginning, we had some problem, in endoscopy, because the Double Health Organization and Ontario Organization defined that provision of FFP2 masks were only for operators that made such case of interventions, endotracheal intubation, cardiopulmonary resuscitation, bronchoscopy, and so on, as you can see, because there is a great risk of droplets and aerosol. But this pandemic is a new event, and so we endoscopists think that we have to change our way of thinking. we see that we are represented the different PPE. The surgical mask, as you can see, is not protective for you, but only for other persons. Surgical mask, if you are COVID positive, avoids you to diffuse the aerosol. But if you want to protect yourself, you must use FFP2 or FFP3 that filters up to 90, 92 or 99% of infection. But however, the problem is that digestive endoscopy is not included among the procedure at high risk of contagion. This is a great problem, because now we have more information. We know that our activity exposes the operators to a direct contact with sprays, droplets, mucus, or saliva. But we know that we have to stay at a distance of 1 meter from the patients. That is not simple, as you know. Also, knowing that perhaps the distance to protect you completely is up to 1.8 meters away. We also had some information about colonoscopy. We know we have the possibility of transmission of the infection via the fecal-oral route, as demonstrated by two recent Chinese studies which have shown a positivity for coronavirus in rectal swabs in half of patients. So we have to protect ourselves with FFP2 masks. This is the message from the endoscopic organization, European, American, etc. Autarky is not working in Italy. Autarky means self-made. Every nation proves to product some masks, but it is very, very difficult because to the lack of suitable materials for construct this mask. The bureaucracy also slowed down the authorization for the use of a simple surgical mask too. For healthcare personnel, we have all now standard precautions. You know, surely, that we have obtained hand hygiene more frequently during the day. Avoid touching surfaces in the immediate vicinity of the patients, because the diffusion is man-to-man, but also from surface to man, touching. You have to obtain a respiratory hygiene, covering your mouth when you have cough, or in its absence, coughing inside the crease of the elbow. Use hydroalcoholic solution for hand hygiene. There will be easily available in all care settings. And finally, disinfect all surfaces with sodium hypochlorite diluted 10%. From the endoscopic rooms after the care of non-COVID patients, you have to remember that you have disposable PPI in special containers. You have to use masks with FFP2 filter. You have to wear a long-sleeved, non-sterile, disposable overshirt, eye protection, cap on your head, alcoholic gel for disinfection, for hand disinfection, changing new glove after leaving the endoscopic room, and so on. The Italian Society of Surgical Endoscopy suggests also that you may use this way of working, applying a surgical mask to cover the entire face, mouth and nose, and introduce the mouthpiece through the small hole in the mask, further reducing the patient's dropping. The pressure negative chamber is the ideal room to do endoscopic examination in COVID patients. At the beginning, there are some measures to obtain isolation technique to prevent cross-contamination from one room to another. Isolate patients with infectious disease transmitted by air. Ideally, there will be at least one endoscopic room with a negative pressure system. But we know that in the majority of cases, this is not possible. So we think that the best way is to perform endoscopic procedure in other rooms, especially at the bedside of ECU intensive care units departments, outside the endoscopic departments. We also have decontamination standards for endoscopy instruments. We have not some news in this field. All disinfectants we use are perfect. The only things is that the disinfectant must have bactericidal, mycobactericidal, fungicidal, and virucidal characteristics. And especially we have to protect the personnels that decontaminate the endoscopic rooms and endoscopic instruments. For endoscopic rooms, you have to remember that coronary virus is stable in the stool and the urine for at least 1 to 2 days. So you have to think that you may at risk of infection if you touch the surfaces in the 2 days after this examination in this patient. If you not obtain a complete disinfection of surfaces and equipment with bleach solution and diluted water 100. If you perform the examination in a negative chair rooms, you have to wait about 30 minutes before to proceed to the next examination. But normally, you perform endoscopy in a ventilated endoscopic room. And after, you have to obtain an air clean and keep the room empty for at least 1 hour before the next patients. Finally, I want to thank Russia, because as you have seen, the autarky, the self-made production is not sufficient for all population, especially for young populations like Africa, Iran, and so on. So officially, I want to thank Russia that this month have supplied Italy with masks, field hospital, and so on. And we will remember forever. Thank you very much.